This is Lauren Bevan. She's the head of health and social care at BJSS. Lauren's background is in the clinical, financial and technology sector. So she's one of those clever polymath people who are not maths that can do parrots that can do algebra. She's just very clever. And she's worked for 15 years on helping the health and social care system in the UK. And you'll probably hear from her how difficult the social care system is to manage. She's worked overseas to help support the system in being more responsive to patient needs, to reduce waste and frustrations of the clinical and operational staff in the sector. And she'll be discussing AI in health tech and specifically strategies and solutions that work for that.
So AI in healthcare, this is a bit of what it is, what it isn't, what some of the challenges and issues of the industry at the moment, and actually how can it help it? So it's a bit of an existential question. Lots of people have got their views about what it is, but here's mine. So I would say about machine learning. So we've got machine learning, which is an area around constructing data and algorithms, and this allows people to look at patient traits, that it looks at various different features, and then it will start to construct an expectation about what happens. We've got unsupervised learning on the other end of it, but I'm just covering sort of supervised learning at the moment. And this is a lot of what Richard's actually been talking about just now, and I imagine that's how his product is powered. Speech recognition. So you've got two main different types of speech recognition. One is voice to text, which is coming in common with things like Amazon Alexa and other devices like that. And also voice recognition, which is slightly separate in that it's, is it you? So it's around looking at your speech cadence and other things like that. So computer vision, this is something where there's a huge amount of focus in the healthcare and AI industry, which is around acquiring, processing and analysing data. So a lot of it around looking at computer vision, looking at X-rays, looking at CT, MRI scans, looking at those sorts of things are covered under computer vision. And there's a really interesting project that Microsoft have been doing in Cambridge, which is called InnerEye, which is around looking at radiological segmentations and doing things that normally take radiologists hours and hours and being able to do it in minutes. So that's an example around benefits around that. So natural language processing, so text processing and text classification. As someone who's got horrendously bad handwriting and as someone who used to have to write quite a lot of medical notes, this is something that is very interesting for them. And unsupervised learning. So there's a huge amount of data that is held in everybody's medical records. By using unsupervised learning, which is throwing a load of stuff into an algorithm and letting the algorithm work out clusters, principal component analysis, things like that, it's a really good way of actually understanding what's linked. A lot of times we don't actually know what's linked, and this is a really good way of being able to make sure that we can see some insights that wouldn't previously be covered by some of our hypotheses. So covered some use cases there, and a lot of these again are covered by some of the things that Richard said. So how can we use this and how can we make this beneficial for people? And I want to be really clear that I think the clinical applications of AI are not about replacing people. Patient care is delivered by people. If you're really unwell, what you really want is for people to actually help you, and you want to be able to make sure that you have some personal contact. So there is something about a healing touch. There is something about somebody taking the time to look at you face to face and be able to talk to you. And I know from colleagues and ex-colleagues who've been working with people on COVID wards, it's really hard to demonstrate empathy and understanding when you're doing it through PPE equipment at the moment. So how are clinicians enabled by AI? So we sort of talk about in BJSS the use of clinicians as centaurs, a sort of hybrid around human plus AI, providing the best therapeutic benefit. So one thing is around surfacing clinical information for healthcare professionals. So when I used to work in hospitals, you used to get notes sort of this thick, so huge bundles of information about people. Complex patients have a lot of documentation, they have a lot of tests, they have a lot of images, and they have a lot of text. Actually, that's really hard to review. And actually, sometimes when you don't have that long with a patient, what you want to be able to do is have that surface for you intuitively, understanding the interaction that that person has come to you for, and being able to quickly understand that information and then be able to give your full attention to that patient is critically important. There's actually a lot of evidence to say that it improves clinical outcomes for people because they're able to have a conversation with you and then you're not looking at your screen. The irony being that we're all looking at our screens all the time at the moment, and that's quite difficult to overcome. The second thing, as I touched on it earlier with computer vision, is medical imaging and diagnostics. Computers are great at finding patterns. Humans are great at finding stories and explaining things. So by using AI and other sort of computer-based diagnostic equipment, it's better for patients to be able to have that looked at by a computer. And this is not around taking people out of the picture, but there is quite a lot of evidence to suggest that computers can see things that people can't. So if I take the Moorfields Eye Hospital work with Google DeepMind, what they've proven through that is that they're able to tell the gender of people by looking at their retinal images. Ophthalmologists can't do that. They're not quite sure how that happens and whether or not it's to do with the vasculature of the back of the eye. But they're able then to be able to say that obviously the computers and the machines are seeing something that humans aren't and have never done and never thought to look for in the history of medicine. And things like that I find really exciting and really inspiring. What else is out there? Literature searches. So it's impossible to stay on top of everything. It's really difficult, even if you're doing it from a subset. If you're a super specialist and you're a world leader in a particular disease, it's still really difficult because the vast volume of medical publications, anybody that's tried to stay on top of what's going on with COVID, what's all the research, what's the treatment, what are the vaccines, what are the data, will know that it's just impossible. So there is quite a lot of work going on with natural language processing to help people signpost the latest evidence or research trials to make sure that people can stay current, because there's no way that you can humanly do that. Those of you who might have heard of Cochrane reviews, so they are kind of the gold standard in medical literature reviews, and they do something called a meta-analysis, which is basically an aggregation of all the current research protocols and research evidence to say what is the best. They've been doing quite a lot of work on something called Project Transform, which is around looking at how you're able to increase the speed that evidence is gathered, processed and put out into the wider ecosystem. And they've been working with NICE and Microsoft around that from a systematic review perspective. So that will mean that we all get more standardised, best quality care quicker because the machine is taking the load for us. Going back again to what Richard was saying around predicting utilisation trends, COVID's thrown out all of the previous operational plans and the previous data that is not useful. I've spent sort of quite a lot of time going, I think it'll probably be a 3% increase on last year. And I can't say that anymore because the data isn't there to support it. So using AI applications and things like supervised and unsupervised learning to understand what's changing, what are the features now which indicate that admissions are going to go up. Do we want to be looking at things like the weather or people, sports teams or anything like that to be able to understand what are the key triggers for elective loading or non-elective loading in hospital care and secondary care. And we all have to get into more complex scenario modelling. Gone are the days where you actually understand what's happening and you've got a throttle on your elective and non-elective capacity. We're just not in that area, and I don't know when we will be again. So actually being able to predict utilisation trends and plan for the areas that you can plan is really important at the moment. Drug discovery next. So understanding biological processes and drug interactions hopefully will help us to find a cure for COVID. You might have seen what's been going on already around some of the trials around repurposing current drugs and understanding what their impact will be on COVID to try and treat some of the symptoms. That's been relatively successful, but that's only been because it's been computer aided. We couldn't possibly have gone through the research trials in the speed that we have and gathered and analysed all of that data with a bit of a help from machine learning. And finally, digital therapeutics. So it's not all about finding out what's happening. Some of it's actually about helping people and treating people. So there's quite a lot of work in mental health at the moment around things like tracking behaviours. So being able to use triggers to understand whether or not if someone's got a history of depression and has been diagnosed with depression, that certain things like internet scrolling into the middle of the night, or not walking around as much as usual, and other things actually coalesce to form a trigger point which signals an intervention is required from a healthcare professional. So being able to do those sorts of things where actually your behaviour change indicates that something has happened in your and you need a sort of clinical intervention also helps. And it helps with reducing the less value-add interactions where people maybe would be checking in every so often, and actually having a way of knowing that your patient's deteriorated and helping to trigger that actually gives some clinicians some peace of mind. And there's also quite a lot around using CBT and other talking therapies, that some people feel happier talking to a robot, and particularly when it's deeply personal. So when people are talking about things like sexual health or other things like that, or addiction, actually having not a human there is something that is preferential, because you are able to disclose, or you feel more able to disclose if you think you're talking to a robot. There's been quite a lot of surprising studies that have gone on around that, which actually indicate that people are far happier to talk about those sorts of things with a non-human entity. So what are the challenges? So the regulatory environment, so Reform, and I've got the link down here, did a fantastic piece of work last year around what's counted as a medical device, what is the testing processes that you need to go through, what certifications do you have. And again, Richard mentioned the litany of ISOs and accreditations and kite marks that's required, quite rightly, to operate as a medical device, because clinical safety is obviously paramount. But it's constantly moving, it's different across the world, all of those barriers exist, but actually finding your own way through it is quite difficult. But so the Reform one, at least for the UK, is a really great oversight of what are all the things that you need to get, what are all the stamps and approvals and people that need to say that everything's okay for you to go to market safely, and also for consumers and healthcare systems to check and make sure that all the checks and balances are in place. Bias is another massive one. So unless people have used national or complete data, there's an intrinsic bias in there. When you're looking at hypotheses, then people introduce their own bias in actually asking the questions, and that's loaded. There's always a lens that's put on things. And a really, I say really great, but obviously really awful example is there's been a couple of skin cancer AI treatments which have been used around looking at photographs and being able to say, is this malignant or not? Some of those have actually been withdrawn because it's found that their training set only involved white skin. And therefore, if you had darker skin, then your chances of actually being diagnosed successfully were limited because it hadn't used a representative training set. And there are obviously other examples of that which are less obvious, but no less harmful. So everybody kind of needs to be more on their guard about making sure, as part of those processes and checks and balances, that complete data sets are used. It's really clear around what's going on, and that the use case is really obvious as well, so that people haven't used a subset of data to do for a globally applicable problem. And explainability. So one of the key things with diagnostics is that people need to understand what steps have been gone through to determine an outcome. So there's lots of stuff in GDPR about it, but there's also a whole thing about trust and transparency, particularly with health data. It's a massive issue that people need to feel comfortable and happy that their data is being used for positive, proactive things, and that the public trust isn't limited to the point where they raise something called a type 2 objection, which basically means you withdraw your data from any use that isn't around direct patient care. The more people that do that, the harder it is to maintain national data sets and other things, because the data becomes more and more partial and it becomes harder to form a view. And then finally, real world applications. Some solutions just do not perform well in the wild. I think everybody's read probably research papers where you go, well, that's really academically interesting, but I've got no idea what problem you're trying to solve with it. It's a great PhD topic, but it's not going to launch your company into the stratosphere, or it's going to be something which is going to sit as a kind of curios on someone's shelf somewhere. So there's loads of stuff around what's being capable of being tackled from AI. So people will take the maths and work out the application. I guess my challenge is, and something that we've been working quite hard on, is actually those aren't the pressing issues. If you start with the issue and then you work out the maths around it, that's a far more compelling way of going about it. And talk to people. This isn't healthcare is a team sport. We all have to play our part, and everybody has to kind of pull together and understand things in order for the system to work effectively, in order for patients to get the best treatment, and also in order for clinicians to feel comfortable dealing with some of these things. It kind of intrinsically impacts on people's patch, and if they don't understand it, they're not going to advocate for it. So understanding the real world application, and that is a sensible thing to do, and that people have thought and considered these things, means that you'll get an easier ride when you come to implement it in the wild. And finally, from me, hints and tips, say useful use cases, and I can't stress this enough. If we weren't in the situation that we're in, then I would say go out there, observe people, observe systems, observe issues, and that will give you your use cases if you're looking to develop. And also, if you're looking to purchase, there is something about seeing really shiny applications and going, wow, that's so cool, maybe we could have that here. But if it's not solving a really pressing problem, it won't get the adoption and spread that you want it to. So is there enough data to inform a solution? Is this a problem worth fixing? Is this a problem that you can fix with what you understand now? And if not, bring somebody else in. Again, it's a team sport. If everybody works together, we can create and deploy and use some fantastic stuff that will just become part of the fabric. Data quality. I sort of joke that most people think that data science is like, you know, doing the really cool stuff and, you know, looking at numbers going up and down. Actually, 80% of it is cleaning data. Consistency in data is something that's assumed, but we can't assume it. Even when it's national, and even when it's something like HES data, which has been going back to 1997, everybody has their own way of doing it. It is more of an art than a science in terms of keying stuff in, and everybody has their own way of doing it. So it's about understanding the context of which your data has been created in allows you to see some of the limitations. And then skills. So sometimes there are some issues with skills to understand the complexity of tasks. So some people get put under pressure to ship when they're not ready, because people just assume you can either get something out of the box rather than it being a kind of bespoke art. You know, it's more kind of Michelangelo than IKEA. So we all just have to be a bit cognizant that this is something that takes a little bit of time, and people want to get it right. It's iterative. It will take time. And then finally, I've gone kind of this far without really touching on COVID, but there's absolutely loads of data out there on something like COVID, and it's a great use case of where you need context around it. So all the stuff that's been happening over the last couple of days around local authority access to Pillar 2 and Pillar 1 testing is a real key understanding around. If you don't understand the totality of what you're expecting to see, you will draw accidentally wrong conclusions from the data that's in front of you. So just keep asking questions, make sure that you understand what you're looking at, make sure that you understand the problem that you're looking to deploy against, and keep asking, keep iterating, and keep going.